Hello, my name is Dr. Ukiri Richard. I continue my podcast on basic cardiology. Today we are going to talk about Amaurosis fugax, one-sided blindness. The case I'm using today is that of an 81-year-old patient that came to your clinic and complained about an experience he had a day ago, which lasted for about 15 minutes with blindness of the right eyes. The patient is known to have a coronary heart disease and had a coronary bypass operation 10 years ago. Before the operation, in the preparation for the operation, he did a carotid sonography where he was found to have a filiform stenosis of the right carotid artery, and he was operated. Despite the fact that he never had any stroke-like symptoms. Past medical history, chronic obstructive lung airway diseases, is a smoker, and you wanted to see what the carotids look like now. My question is now, what ultrasound criteria do you know for the exact grading of carotid artery stenosis? For the Doppler sonography grading of carotid artery stenosis, that's the internal carotid artery, there are different techniques we use in all day. The most widely used worldwide is that of the NASCET, NASCET or ECST study, which is actually after the common carotid CC method. Because in last years, many values are coming up in the grading of the carotid stenosis. In 2003, a consensus paper was published in America by Grant and all, so as to help to give a standard of grading the carotid stenosis, which I'm going to tell you now. So according to the American grade scale and Doppler ultrasonography criteria for the grading of internal carotid artery stenosis, you have normal, mild, which is under 50%, moderate 50 to 69%, and severe above 70%. You also have subtotal and total. In the mild internal carotid artery stenosis, the maximum peak systolic velocity is less than 125 centimeters per second, and there are no plaques. And the ACI, that is internal carotid artery ratio of the common carotid artery, is less than 2. Here also, the internal carotid artery end-diastolic volume is less than end-diastolic velocity is less than 40. So that was that of the mild, normal internal carotid artery, maximum velocity less than 125, no plaque load. ACI to ACC relationship less than 2, and end-diastolic velocity of less than 40. The mild stenosis under 50%. There you see have the maximum velocity under 125, but there you have a plaque load of less than 50%, and the relationship between the internal and common carotid artery is still less than 2, and the end-diastolic volume is still less than 40. So the only difference there is that there's a plaque load, but with less than 50%. Now, the moderate internal carotid artery stenosis, which is represented between 50 to 69%, the peak systolic velocity is between 125 to 130. The plaque load is more than 50%, and the relationship of the common that means the internal carotid has a higher flow than the common carotid with a relationship of 2 to 4, and the end diastolic velocity is between 40 to 100 millimeters of mercury. In the severe internal carotid stenosis, the flow is above 230. I think the moderate is 125 to 230. Yeah, 230. In the severe is more than 230 millimeters of centimeters per second, with a plaque load more than 50%. But here the internal carotid artery has a flow of more than 4 times the common carotid artery, and the end diastolic velocity is more than 100 centimeters per second. You also have the subtotal and the total internal carotid artery stenosis. In the subtotal one, the peak systolic volume may be high, low, or cannot even be found. The plaque load will be very, very visible, but the relationship of the internal and common carotid is variable. Also, the end diastolic volume is variable. And in the total stenosis, the peak systolic velocity cannot be found. Plaque load can be seen, but you cannot find any lumen. You cannot use the relationship of the internal and common carotid artery, and you do not have end diastolic velocity. It is worthy of note that these American criteria have good orientation with the NACET criteria, and also a good correlation with the angiographic reference values according to the NACET criteria, which is the distal stenosis grade, but cannot be compared with the ECST grading of the internal carotid artery stenosis. In 2010, the Germans did a revision of the DEGUM criteria, and the corresponding values with the NACET stenosis grading was published. The postulated values here showed great variation from the 2003 published consensus paper of the USA. So at last, it actually depends on the institute or the praxis, clinic or hospital to depend on which of the above named stenosis quantification to be used. The DEGUM ultrasound criteria for the grading of internal carotid artery stenosis and to lay down the NACET stenosis grade has main criteria and additional criteria. In the main criteria, you use values gotten from the two B mode ultrasound and color mode ultrasound. You also use the peak systolic peak velocity flow, and you also use the peak velocity flow at the post stenotic level. Then you also use the presence of collaterals. The additional criteria are the diastolic flow pre-stenotic, the post-stenotic flow, the end diastolic flow in the maximum flow in the site with the maximum stenosis, confetti signs, and stenosis index, which is internal carotid arteries flow to external carotid to common carotid artery flow relationship. Well, in the bi-mode, bi-mode can only be helpful when you have a stenosis lower than 40%, and the color Doppler can be used everywhere. But the other criteria come into play when you talk about stenosis 50% and above. Don't forget that we are talking about the incorporation of the DEGUM ultrasound grading into the NACET stenosis grading. So 50% here is when you have a peak velocity flow of 200 to 250, and you have a post stenotic flow and end diastolic flow in the maximum stenotic position of less than 100, and the internal carotid to common carotid index is more than 2, then it's 50%. I think I'll jump this because there's much difference between the NACET definition and the ECST definition in terms of percentage. But then, if I continue with the NACET, 60% is flow above 250 centimeters per second, with end diastolic flow of less than 100 and more than 2 relationship of the internal to external. 70% has more than 300, with 50% post stenotic maximum velocity, and end-diastolic of more than 100 with a relationship of more than 4. 80% you have 350 to 400 with a still maximum systolic flow post-stenotic of less than 50, and an end-diastolic flow in the maximum stenotic area of more than 100 and a relationship of more than 4. You have an occlusion when you have, this thing is very confusing. The problem now is that most of these findings, the percentage where NASED is 50, you have ESCT as 70. Where NASED is 60, ESCT is 75. So it is very, very difficult for me to break them down. So I'm asking you my next question. How do you define a symptomatic carotid artery stenosis, and which typical symptoms do you refer to as relevant? Usually, a stenosis of the internal carotid artery can become symptomatic when you have symptoms not more than 180 days. History highly suggestive of a cerebral ischemic reaction in the area of the internal carotid artery are one-sided symptoms in form of an extremity or face concentrated sensibility or motoric alterations, which could be paresthesia or paralysis. In the visual symptom, it could be a temporary or permanent one-sided blindness, which is Amaurosis, or the loss of half of the sight field, which is the homonymous hemianopsia. A contralateral eye deviation, where the patient looked to the other side, is also an indication of a carotid artery stenosis mediated cerebral ischemia. Sometimes dysarthria, which is seldom, and aphasia can also come up when there are focal ischemia in the corresponding brain area. So when you are making the diagnosis, you have to know exactly when the symptoms started, the severity and character, so that you can differentiate it from migraine. It could be a progressive manifestation of the symptoms. It could be fibrillation of the eyes, paresthesia, and sometimes no paralysis. It is worthy of note that carotid artery symptoms does not involve syncope, formatio reticularis, does not involve dizziness, it may come from the vertebral artery, does not involve tinnitus, diplopia, dysphagia, ataxia, double vision, and headache. So you did the sonography of the carotid artery, and on the right side you found, as expected, an 80% according to ECST grading, 80% stenosis of the right internal carotid artery. What are you going to do? Generally, a possible fast approach is indicated. Patient with high-grade internal carotid artery stenosis and recent symptoms profit very well within the first 2 weeks of the presentation for an invasive therapy. This is only possible in patients with reversible ischemic cerebral attack, but not for patients with persistent symptoms. Within this time, the incidence of a repeat or another cerebral infarction is very high. Good. What patients do you think are fit for surgical? Which patients are fit for interventional therapy, and which patients do you think are fit for medicated therapy? How do you decide? What do you depend on this decision on? The decision has to be made based on the risk profile of the patient. Let's deal with asymptomatic patients. The incidence of a cerebral ischemia in patients that are until now asymptomatic lies with maximum conservative therapy of about 2 to 5% in a year. Well, this count does not include the patient that have maximum medicated primary prophylaxis and got serious progression within the last years, and does not include the individual risk factor and the stenosis morphology. Because of this low rate of occurrence of cerebral ischemia, there's an advantage for a carotid TEA only in patients with high-grade stenosis above 60 to 70%. Those ones only those patients will benefit from a carotid operation, TEA. The indication for an intervention, a percutaneous carotid intervention, is presently given when you have a high-grade stenosis of more than 70%, according to the NASET criteria. According to more than 70 to 80%, according to the NASET criteria. There are some indications that women above 75 of years very little or don't even benefit from invasive care of an asymptomatic carotid artery stenosis. So the criteria for an operative or interventional therapy in asymptomatic patient are a fast progressive stenosis formation or an unstable plaque structure. By asymptomatic patients, you must have a life expectancy of at least 5 years and a positive benefit of this intervention. Generally, the evidence data for primary prophylaxis in patients with high-grade carotid stenosis are very, very weak. Maybe in the future we'll get some clarity. But now let's come to symptomatic patients. Which one will benefit from surgical intervention or medical therapy? Well, we see this very differently because the stroke rate here is about 10 to 15% per year. So in this case, the carotid operation, which is the carotid TEA, has a very significant improvement of the prognosis in cases of 50 to 69% and also in cases of 70 to 99% stenosis. There have been a lot of studies to see the acute and long-term results of the carotid intervention compared with the carotid operation, but because of the lack of special methods, the studies are not really reliable. One study showed a comparable peri-operative complication in the operative and the intervention methods. The surgical revascularization has a higher incidence of peri-operative myocardial infarction, but according to a study, it has very, very few cases of minor strokes. In the long-time control, both methods have the same patient outcome, so that in cases of above 50% carotid stenosis, you can consider the intervention or the operative revascularization. Many national and international associations have been requesting for peri-operative and peri-intervention, that means between 30 plus minus 3 days complication rates, which have been shown to be 3% in asymptomatic and 6% in symptomatic patients in both treatment options. But a few criteria can help you to decide which patient to use intervention for and which one to use operation. High risk patients for an operation are patients that have clinical relevant coronary heart disease, severe pulmonary disease, contralateral coronary carotid artery stenosis occlusion, contralateral larynx nerve damage, or a pre-existing radical neck operation or radiotherapy. Patients that have restenosis after the carotid TEA, TEA means carotid endarterectomy, and patients above 80 years. All these patients, they are not fit for operation. Patients that are not fit for intervention are when the vessel involved has a complicated anatomy. For example, when there's a tortuous projection of the artery, patients that have renal insufficiency. Okay, now let me ask you another question. You now want to send this patient to the cardiologic department. Which tests should be carried out in terms of therapy evaluation of this carotid stenosis. In case of a relative recent symptoms, definitely you need to do a picture of the brain, either computer tomography or magnetic resonance tomography. Here you will try to visualize the ischemial area, especially if there's a transitory symptoms like TIA or Amaurosis fugax. Well, you may not see anything, but you can also see other or exclude other pathologies like tumor, aneurysms, chronic subdural hematoma, thrombosis, and arteriovenous malformations. If in the computer tomography you do not see anything, then you really need to do other tests or include other management measurement that will help to know other factors that may cause the presenting symptom. For example, an ophthalmologic consultation to check for a differential diagnosis of an acute ischemic optic neuropathy, neuroplastic neuropathy, retinal vasculitis, and papillary edema. You also need to do neurologic consultation to check for differential diagnosis, which could be multiple sclerosis from optic neuritis. It could be peripheral nerve lesion, it could be myasthenia gravis, or psychogenic disturbances like hyperventilation. You need to do Doppler sonography of the carotid artery to verify the grade of the internal carotid artery stenosis and to exclude irrelevant contralateral internal carotid artery or an occlusion, and also to occlude stenosis of the other neck vessels. You need to do a blood pressure Holter monitoring to clarify inapparent hypertensive derangement, which is helpful in risk factor screening. Then you need facultative examinations like transesophageal echocardiography. For example, if you have deep vein thrombosis or coagulopathy, to exclude a paradox embolism, you have to exclude intracardial thrombosis in patients with atrial fibrillation. You need to do transcranial Doppler sonography to check for paradox embolism and to evaluate for intracranial circulation and to check for collaterals. Coronary angiography may be considered if you have the symptoms like unstable angina pectoris. So depending on finding, you may think of revascularization of the coronary vessels, the coronary operation, or intervention. Irrespective of the computer tomography finding of the brain, you still have to do other screening which will help you to find out other pathologies that will or that may influence your treatment decision in the carotid stenosis. In this case, you need to do Holter ECG to check for atrial fibrillation, where the patient will need anticoagulation. You need to do echocardiography to screen for pulmonary hypertension, right heart or left heart dysfunction, which check for other signs that may be indication for anticoagulation or elevated operation risk. Or you do a Doppler sonography of the leg arteries, especially if the patient has a known peripheral arterial vascular disease or if he has a strong torsioning of the vessels, so that you know this patient will not be fit for a coronary angioplasty. Thank you very much.